Okay, hello everyone. My name is Hamad Ektiari. Delighted to be here. Starting with a case presentation, just giving you an overview about what we are going to discuss today and what are the clinical implications that we are going to further discuss together. So we have Mr. JD, who is diagnosed with MDD. He has been receiving different treatments during last 15 years. Partial response to different medication, received therapy. He was not very happy about that. And also, he started to drink and now escalated over kind of higher number of drinks, 6 to 8 drinks per day, meeting criteria for having alcohol use disorder, moderate to severe. And there are some attempts for abstinence, okay? And now he is already in a program working with a group of clinicians in terms of being able to bring down number of drinks that he has. And also he's interested to receive further treatment for his depression. And he has been assessed for TMS. And now there is a discussion in terms of, okay, if we have a case like him, who already reduced his drinking behavior to 2-3 drinks per day, and also he has some episodes of binge drinking every 2-3 months right now. He's planning for total abstinence, but he's not totally abstinent right now. Can we start TMS for him? And some discussion questions in terms of, do you consider him as a candidate for TMS? Who says yes? And who says no, I'm not considering him as a candidate for TMS? Okay, so there are people who say it's going to be hard for him to receive TMS.
Maybe.
Or maybe. Okay. And then thinking about, okay, if we want to prescribe TMS for this person, what would be the safety considerations? How we can consider safety things to prevent any major side effects with TMS?
Decides to stop drinking out of sudden, the problem.
Okay.
What about the seizure risk?
You want to reduce seizure risk. What are the other considerations that you want to consider? Driving to the clinic every day is going to be
drinking.
Mm-hmm. And if he's drinking, okay.
How much of his?
So it's an important question in terms of, okay, which one is the main driver? Is it depression is contributing to the alcohol, or if he basically stop drinking alcohol, the depression is going to go away? And we know that he has started to have depression since he was around 20 years old. So the depression precede alcohol use, at least from, historically based on the timeline of presentation. But that's a good concern and question. What are the other things that you consider in terms of the safety or indication for him?
No contraindications, no medical advice?
Oh, of course, any contraindication that would be related to TMS part, making sure that we are considering those factors. And how alcohol use while people are receiving TMS might impact the efficacy of intervention. And is it going to be something that you exclude people or you consider as a contraindication, say, okay, if somebody is receiving alcohol, there is no effect for TMS, so why bother? And should we just exclude those people from receiving TMS?
Depends on the severity of the alcohol use.
Depends on severity of alcohol use. What are the other considerations? Do we exclude people based on receiving any specific psychotropic medications or psychotropic agents? Saying that, okay, if somebody is on benzodiazepines, we are excluding them because it's not going to work. And is it easy if somebody is taking benzodiazepine for a few years and just saying to them, just stop taking benzodiazepine for a few days because we are going to do TMS? Or asking people that they have been kind of drinking to just please stop being abstinent for a month and then we will start TMS for you. Okay.
I don't have a lot of experience, but would you have trouble dialing in the motor threshold with variable use of alcohol?
we can discuss that. That is exactly the type of things that we want to discuss today in terms of what are the safety considerations that we need to consider, what are the effectiveness considerations that we need to think about, and also how those things could be integrated to treatment. Just making sure that people will have access to the best evidence-based treatment that could be potentially available for them. And I'm going to stop here and hand over to Professor Brady to